Good morning, everyone. Again, I just want to really thank you all for being here in Detroit, supporting our city, and hope you're enjoying the conference and also getting a chance to enjoy some of the nice area around here. The title of this session is Geometric and Dosimetric Uncertainties. I'm going to focus more on the dosimetric uncertainties, and then Sonia Dietrich from UC Davis will cover more on the geometric uncertainties. All right, here's my disclosure. My department receives research support from Varian Medical Systems and Philips Healthcare. All right, so let's begin with this idea of complexity in radiation therapy. And I think few would argue that SRS and SBRT procedures are highly complex, right? I mean, this is the highest level of complexity, arguably, that we have in our field. Why is it complex? Well, we're dealing with a small number of fractions. Stereotactic procedures are generally a single fraction. SRT and SBRT are typically less than 5 fractions. The dose per fraction is really high, right? Remember, for trigeminal neuralgia, you're giving single fraction 70 to 80 gray. Spine, depending on your practice, we're routinely doing 18 gray, but you can go up to 24 gray in a single fraction. And then SBRT can be up to 18 gray in 3 fractions. You're dealing with small fields. Typically, these lesions are very small. So you're looking at field sizes from 3 cm down to 5 millimeters. You can actually, we've treated many cases where you're dealing with lesions on the order of millimeters. And SBRT is typically less than 5 centimeters. So all of this really means that the treatment planning model, how you define your targets, how do you do your dose calculation and dosimetry, and how you localize the target, all have to be extremely accurate, right? There's no room for error here. We're talking about millimeters. There are real consequences if you don't get this right. And here are a couple examples of this. So this is a slide from Tim Solberg, and it reviews a couple incidents that happened in Paris. And the first one you're seeing there is in the first series, there were 33 patients with 57 brain mets. You can see that the mean overdose was 61.2%. Fortunately, no morbidity was observed, but obviously this is an extremely high overdosage. In the second series, acoustic neuroma patients, there was a 31% 12-month actuarial rate of trigeminal neuropathy. And this was as a result of the fact that the output, small field output factors were not properly measured. They used large detectors and didn't get it right. So if you have any doubt about the fact that this is a difficult problem, both from a measurement and a calculation standpoint, then hopefully I can convince you with this next slide. This is a survey of 40 identical SRS Linux. The physicists were asked to measure 6 by 6 millimeter field defined by the MLC. And what you can see here is this remarkable level of uncertainty, discrepancy between these measurements, in 45%. Down to, on the order of 0.45 here for the one that was kind of an outlier. So, right, this is identical units, you're making the same measurement, and you have a 45% variation. So this was this problem, and the task group 155 hopefully will be published in the next year. We're looking forward to that. There are a couple important references, and the first from Das and his colleagues, small fields, non-equilibrium radiation dosimetry. This group of folks is involved in AAPM Task Group 155. There's also an excellent report, which I would recommend you read, from the IPEM, the Institute of Physics and Engineering Medicine, the AAPM equivalent in Europe. This is called Small Field MV Photon Dosimetry. So what is considered small? Well, if you read the papers which quantify the term small, depending on the size of the source, projected from the detector through the beam aperture, the size of the detector used in the measurements, and the electron range in the radiated medium. So all of these factors contribute to the definition of small. Occlusion of the effective photon source. This is an important issue, and it has a significant impact on your profiles at small fields. So let's look at this. On the left, we're looking at a larger field size. If you stand at the location of the phantom and look up the source, you're not eclipsing any component of the source. You see the entire source here, right? On the right, you have a really small field size, and if you stand at the location and look up, you're eclipsing the source, as you can see in this picture. What does that mean? Well, you're only seeing a fraction of the source. Now, if you think of the output, right, the width, the height of this profile, as being proportional to the total fluence, right, and you're only seeing part of the fluence here, clearly then you're going to have a lower output, right, a lower magnitude here. So if you think of the fluence as being an integral over the line here, right, if you're only seeing a part of that line, then you're going to have a significant reduction. And what you're seeing here is now some simulations looking at a 6 MV beam with the full geometry, meaning you're not modeling the entire source, but just a point source. And what they did was kind of smart. They scored Kerma instead of dose. What does that mean? So if you remember now, if you're scoring Kerma, you're stopping the electron, right? You're assuming the electron deposits all its energy at the point. So you're taking the electron transport out of the picture completely. So you're looking at photons only. And what you see is interesting. As you get down to about less than a half a cm, you see this significant reduction here when you simulate the full geometry, right? So clearly now, there's no electron transport. This is due to the fact that you're eclipsing the source. This is photons only, whereas you don't see this effect if you have a point source. All right, so we've done some work with this in this area also with Monte Carlo simulations, and this is from Cindy Chen, one of our physicists. And what Cindy did was looked at very small field sizes with beam NRC Monte Carlo calculations. And so we looked at a half by half cm, 1 millimeter calc grid. On the left, so what we did was we said, let's see how good the treatment planning system does. Millimeters, so if you look at this compared to the Monte Carlo, you can see that clearly if you use a 0 millimeter source width, it doesn't match quite. You want to keep an eye on this, right? If the motion is greater than about 1.5, 2 cm in that range, then you should try to avoid doing rapid arc or doing the rotational delivery, so you have an opportunity to see more of the interplay effect as the tumor is moving, right? But you have less modulation. With IMRT, you have a fewer number of beams, but each of those beams is more modulated. So if you have fewer number of beams, less opportunity to see interplay, but small field dosimetry is complex, and measurements must be performed with significant attention to detail. Appropriate detectors should be chosen for the particular measure. Pick up the phone, call your colleagues, folks are willing to help out. Independent verification of the small field data and associated beam model is helpful. This is a really important point. So in addition to doing your IROC TLD measurements, you should try to, if you can, try to get the lung phantom and do testing on your beam model before you treat the first patient. We've tried to implement this for all our machines. We get the IROC phantoms, we radiate them, send them back to ensure that colleagues who helped me with this presentation. I'd like to thank the APM and RSS program committee, and I'd like to thank you for your attention. Again, thanks for being here in Detroit. We very much appreciate your support.